Patients undergoing joint replacement surgery at Norwalk Hospital experience improvements in pain and function earlier than state and national averages.
On this week's Health Talk, members of Norwalk Hospital's Joint Center's team will explain what they do to help make the patient experience and clinical outcomes so positive. So stay tuned.
We are up next.
Hi, I'm Dr. Eric Mazer.
And I'm Dr. Vicki Smitak. Today we're going to discuss joint replacement surgery with Dr. Mark Fletcher, who's an orthopedic surgeon, and Deborah Kane, clinical coordinator of the Comprehensive Joint Replacement Center at Norwalk Hospital.
You have the longest title.
Yes.
So anyway, yeah, joint replacement surgery become a really common operation. I mean, it seems like lots of folks are getting it. I think we discussed before the show, as we baby boomers get older, and we're not sort of giving up yet, and so we want. What have been some of the changes that has made this such a successful surgery? Maybe we'll start with Mark.
Sure. You know, they've been developing the surgery for 60 years, and so way back when, it was always an item of last resort. But as technology has improved in terms of the implants and our ability to deliver them, it's become more of a quality of life issue. So people come in and they can't do the things they want to do. All of a sudden, you know, when joint replacements now can routinely last 20 years or longer, now we want to give people back the quality of life, get them back to work, get them back to their activities, allow them to play with their grandkids. And certainly as people, you know, as our newer generations come through, we're much more active. We want to ski and do all these things as we become older. And so the joint replacement becomes more for maintaining that quality of life. And so,
but the technology has also made it so much more palatable, right? I mean, it's not this big bad surgery anymore,
well,
as it might have been for hip, for example. And now, you know, patients are going home fast. Maybe either of you can talk a little bit about that, the recovery process, and how quick, or even the surgical aspect of it, how quick it is.
Well, I'll jump in and I'll give Deb as a segue. You know, the implants we're talking about, they've become so much tougher. So that's the first one. Like they resist wear so much better than they used to. So that's number one. Number two, the surgical approaches have changed. That we've become much more minimally invasive. You have to get in there somehow, but we've become better at getting in and getting out with less damage. And so those two are very important. But the third has been our ability to control pain very well, and then aggressive physical therapy. And so that's, I mean, something that, you know, I can talk to you as a surgeon, but also Deb can as the coordinator of the Joint Center, because that's how all those things come together.
So you see patients obviously after they've had their surgery, and I know that you coordinate all their care as the coordinator of the Joint Center, but even as your clinical role as a physical therapist, what are the differences that you see now as compared to, I don't know, 10 years ago when patients were having these surgeries?
Very sizable differences. I think the main thing is just patients' ability to well tolerate the anesthesia that we're using is different and has less of an impact on the patient. It's enabling them to get up and actually ambulate on the day of surgery. So the patients are getting up. On average, our patients are staying in the hospital less than 3 days, which is a big difference from years ago. And most of our patients are going home.
Well, that's pretty amazing, because I remember not that long ago, we were busy coordinating post-operative care with nursing homes because people would go for 2 or 3 weeks of rehabilitation before they could get home, and now people are being discharged straight home, and because their function is so much better. It's really kind of amazing.
Does that tie in largely to pain control? Are we doing, I mean, how much of that is a factor as opposed, I mean, I guess everything factors in, but maybe let's talk a little bit about pain control, because that's what's scary, I think, to most people when they think about surgery.
For sure, and that's the one thing they experience. You know, they're not really present for the actual surgery, but they know what happens afterwards. So I would tell you that many things we do, that's the only thing that really matters to the patient. You know, so, and I talk to people in the office a lot. If I say right after surgery, someone's going to come in and say, well, we need you to get up. The only way that's a reasonable question is if you feel okay about it. And the only way you feel okay is about having your pain well controlled. So it starts even before surgery. We start giving people some medications that turn down the signals, the different pathways pain can travel in the brain. So before things can even get excited, we want to shut them down. In surgery, we use like anesthesia. It's akin to like the dentist numbing your mouth. So we numb your legs up with a little bit of numbing medication. We inject some medications around the hip itself, and then even after surgery, we keep on using medications. You know, not only some narcotics, but other medications that turn down the different volumes of the pain. And so when you wake up, you know, I'm looking at people a day or two afterwards, and I'm more shocked now when I see that they've had pain. Mm-hmm. I expect them for the first 24, even the first 30 hours, to have very minimal, if any, pain.
That's really
We've had several people, usually, you know, actually females, but older females. We've had several people who've gone through a whole joint replacement, a whole hospitalization without taking narcotics.
So that approach, that's a really novel approach.
Which is really amazing to me. And I mentioned I practiced clinical oncology for many years, and largely for, and again, it's a different kind of pain, and I understand that, but all we could do was sort of ratchet up the narcotics to higher and higher doses. And yet this post-operative approach with local anesthesia, non-competing pathway blockage has really changed the whole picture of what it's like.
But even preemptively, and I like that you said that you start even before the surgery, so it's like you're prepping the nervous system and the pain receptors to downgrade them.
People always, you know, you don't want to chase it, because if you chase it, you have to
overdo it. That was the rule in oncology too. Once it got there, it was it reached a peak. It was much harder to control it than to maintain it at an acceptable level.
And you know, a lot of it is just getting away from narcotics, because really the side effects of those medications keep people in bed. You know, they feel nauseous, they get dizzy, they get itchy, you know, they just feel drugged up. And so if you can decrease those medications, they have their own role, but if you decrease the overuse of that, then they feel like real people, and they want to get going.
Just to put this in context, a lot of this happened as a result of the decision to create a joint replacement program. And I think that while we're speaking specifically of Norwalk Hospital's joint replacement program, it really is a good example of what can be done when people from multiple disciplines sit down together, agree to standardized protocols and standardized care, and then measure what they do. And I've seen the evolution of this in this particular program, and I think it's really a credit to all of you, but also quite remarkable what's been achieved. So maybe you could talk a little bit about how this came about. I guess you both came in as it was going on, but still, tell us a little bit about some of the protocols, what people had to agree to, some of the things that were researched in order to get this level of accomplishment. Deborah?
Well, really the key is, as you said, having the multidisciplinary team, a team that's highly engaged and very passionate about joint replacement. And it means engaging everyone from pharmacy, anesthesiology, physical therapy, the PA team, the OR group. It takes, as they say, a village to make this happen. And what we realized when we began this program is that when you talk about the patient experience, it's not just about what happens while the patient is in your care at the hospital. The patient experience actually begins far ahead of the time of the surgery from the time when the patient schedules it. It's about establishing communication between the surgeon's office, between our team at the hospital, so that everyone's really involved in educating the patient and the family, and that we're thinking ahead to setting the expectation of what they can expect when they're in the hospital, and then what will happen beyond.
Yeah, you take the mystery out of it, you take a lot of the fear out of it, and that communication I think is really important. People want to know what to expect more than anything else.
Do patients get exercise regimens before they go in to begin to strengthen the joint? Because I presume there's disuse, atrophy of some of the muscles when say the knee is so sore all the time, and you'd want those muscles as strong as possible going into the surgery, don't you?
Yeah, for sure. And actually, and you can look at it research-wise, the non-operative treatment of these problems, physical therapy is one of the cornerstones, because it makes you more efficient, it makes you stronger, it makes you, use your body more efficiently and not isolate just one piece. So even before they even are a candidate for joint replacement, we're emphasizing the need for surgery. The need for exercises.
Right. Going back to the standardization that we talk about this a lot, not just in joint replacement, but in modern medicine in general, we figured out that, sometimes less variability is probably better for treating entire populations, treating specific disease processes, et cetera. So have you found, Mark, and I'll ask you as a surgeon, I mean, it takes surgeons coming together and saying, hey, we're all going to do this in a very similar fashion. You can't have an outlier who's going to say, no, gosh darn it, I
Yeah.
still want to use narcotics 100%, right? So talk a little
Right.
bit about
Well,
that and how
and-
it is to get a team of doctors to agree to do things
and it's-
by protocol,
right,
which used to be a dirty word.
You
I
got
remember
it.
when I was training.
Well, it's like herding cats. You know, everybody's got their own ideas of things, and everybody's right. And so the only thing you can do is you really have to pull the existing literature and say, okay, how can we as a group get better? And so you have to standardize things, and not just as the surgeons, but also the anesthesiologists.
That's right.
What kind of blocks are you doing? What kind of medications are you using in their things? And then standardizing the physical therapy care. So everybody's got to come together. Now we all have some idiosyncrasies that we just have from training or whatever, but we have to agree on the big things.
Yeah.
And so we have to agree that everybody's going to put any weight they want on a joint afterwards. We don't have any restriction in terms of range of motion.
So
we
that
just
was a
knock
big
off the big
thing
things,
that people
right.
had to agree on.
And then we have to you have to have some sort of, if you make people agree to these things, you also have to prove that it's working. So quarterly we follow many different parameters in how people are doing. Not only outcomes, readmissions to the hospital, their overall feeling, how they felt, how far they walk, and so we have to make sure that we're doing the right thing too. So that's how we can continue to refine it.
Yeah. No,
This
that's
is
great.
really the growth of new medicine, if
Right.
you will. And
That's
I think
right.
it's really been fascinating for me because I've lived through both eras. But this, when initially presented, a lot of the older docs said, well, this is cookbook medicine.
Right.
It's never going to work. I know what's right for my
Right, that was
patients and
always
nobody
frowned
else
upon,
does.
that cookbook medicine
Yeah.
mentality. I remember using the word protocol once when I was an ICU resident or fellow, and my attending looked at me and said to me, Dr. Smitak, if you like protocols, you should be blah, blah,
Right.
clearly not being in an ICU setting.
Yeah.
Here we think, we use our brains.
Yeah.
But
And-
that
and
was,
it's
I think
moved
that was
so much from that.
exactly an antiquated
Yeah.
approach because now we have evidence
Yeah.
about what works and what
Right.
doesn't. And just because you think that from your
Right.
anecdotal experience doing such and such
Right.
is the best,
Right.
there are studies out there that may say you're wrong.
Yeah.
Uh,
And you could be doing it
And you
better.
could be doing it better.
That's right.
And I think this is proof.
Yeah.
I mean, things like you give intravenous Tylenol,
Right.
which I'd never even heard of before
Right.
joint surgery. I'd heard of Tylenol, of course, but never get. And it apparently it's a much stronger drug.
Well, it allows it to get to the body without the liver pulling it all out. So it's so you get that first
and
pass.
patients get a lot of relief.
Yeah.
Where I usually think of Tylenol as a minor pain
Yeah.
reliever.
Right.
We're talking about acetaminophen,
Right.
the generic equivalent, but it works.
Yeah.
It's and it doesn't have the nausea or
Yeah.
any of that's not all that's done. But I think it's pretty special.
Yeah, and I think we use our brains. I hope we use our brains. We're always trying to figure out a way how can we get better. And so, but you also have to look out for the outliers who people don't actually fit into the protocols too. So you have to really keep your wits about you
Yeah.
to make sure what you're doing continues to be appropriate, and you have to make sure, have we gone too far on this one end? Do we need to get better on this other thing? And so we continually go through our data and listen to the outcomes. So we really want to be outcomes based.
And this is modern medicine.
That's
So I want to continue this discussion after the break. I'd like to talk specifically about people at home. What should they look for? What are the
Yeah.
data that they should be looking at to tell a good program apart from one that is not as
That's
good?
right.
Certainly meaningful. So we're going to bring you back after the segment and stay with us.
We are back with Dr. Mark Fletcher and Deborah Canet, and we've been talking a lot about joint replacement surgery. We have a great program at Norwalk Hospital that our patients seem very satisfied with, and maybe we can talk a little bit about that, Deborah, the patient experience. And first of all, how surprised are patients when either you or Mark tell them that they're expected to get up out of bed so soon after the surgery? Do you get still a lot of disbelief? Do you get some
Or that
resistance?
they're going to go home or maybe just on Tylenol.
Right.
Yes, people actually are quite surprised. I have the privilege of being able to meet all the patients and their coaches early on. All patients attend a pre-op class, so we talk a lot about what they can expect through the experience. And I always give them the statistic that by the time they leave the hospital, 80% of our patients are able to walk the length of a football field. And that really surprises people, but it
Wow.
really speaks back to things we spoke about earlier with the pain management, with the surgical technique, but also very much about the team aspect. Our program is very much built on the patient experience and that this is a well patient. Our patients seem to really like that they will be cared for on a unit that's segregated from the rest of the hospital. So all of our patients are dressed in their own clothing, and they know that they will be getting up and ambulating. I think it actually puts them at ease because
well,
they
that
know
alone is a psychological lift that you're not wearing the Johnny code
Right.
with your backside exposed. You actually have your regular street clothes on or something comfortable that you have from home.
exactly.
You don't have somebody with a big abscess in the room next door.
And that too.
Right. And I think also just our unit works like a well-oiled machine because the team, this is what we do, this is what we specialize. So patients like that when they come on our unit, they will be surrounded by other patients who are going through their same journey. So there's a lot of energy that is generated. And the other thing during the class that I
Do you
go
ever see
over,
long-term relationships develop from
absolutely.
bonding over joint surgery?
Absolutely, and we do have group therapy classes in the afternoon, so the patients do get to know each other. And because we engage the patient's coaches early on, it's not just about the patient, it's about their social network, getting them on board so that their outcomes are better in the end. And that's another thing we do track is our outcomes. We survey our patients before surgery, so we establish a baseline. And we also repeat the survey after surgery. So because we have the ability to track their outcomes, we know that one of the biggest things patients struggle with before surgery is climbing stairs, walking, all of the common things that patients say, am I going to be able to do this better? And when we say, yes, you will, we can say that because we track it.
Yeah.
Yeah, a lot of, I think medicine up until recently, people would say I'm good because I say I'm good. And I know I do a good job because I do a good job. And in this modern era, data, prove it.
Yep.
Prove it. And you guys are certified also by outside agencies, by the Joint Commission, I believe.
Correct.
Yes.
And that's something patients can look for, even outside of our catchment area, that for a program. You would really want a certified joint replacement program, wouldn't you?
For sure, and there's also a national database of joint replacement programs and things like that we can compare ourselves to, and it kind of it has the bar where we want to achieve, and so we take that very seriously.
And it's legitimate for patients to come in and ask that of their surgeon,
sure.
of the.
Yeah.
I mean, what are your outcomes? And so maybe we can talk a little bit about what should they be asking. What are the marks of a good program? Let's take easy one, surgical infection rates, right? That would be, they should be pretty rare, I would think, because these are healthy patients going in.
And they're up, and it's a surgery that's brief. We minimize their medications, so they try to be optimized ahead of time. So there's a lot of things that go into it. I think the other one is volume of joint replacements. So the more that a regional center does, the better they are at it. Right. And so, we have a team here that does nothing but. So, and that it multiplies and it rolls on itself over time and becomes better and better. So, volume of surgery.
And I think other things that I encourage patients to ask about are, besides infection rate, are complications, readmissions. We have a very low readmission rate. So we know that when we get our patients home, and the majority of our patients are going home, 85%.
That in and of itself is pretty unusual, isn't it? Because I remember early in the days of this program, one of the metrics used to be what percentage of patients do we send out to a nursing home who need additional rehab? And 85% to home seemed pretty, I think we're around 50% then, or 60, seemed unachievable, and yet and that's, you're not sending people home who aren't ready to be home.
Right.
Exactly.
They're really that much better.
Yeah.
And we're not seeing them come back as readmissions. So we know that this plan is a good one, and we know that patients are psychologically a lot happier going home. So, and this just goes back to...
What are some good numbers, Deborah? What are good numbers in terms of getting people home, complications, et cetera? What are some, not to get into the weeds, but on the other hand, if somebody's sitting home thinking about this, they should be able to ask their surgeon, their program, these facts and know where they are.
And these are things that hospitals should be transparent about. And we certainly are being, and this is what Dr. Fletcher was referring to, is that because we are a part of a database, we have the ability to compare ourselves with other hospitals. So we know that, for example, our complication rate was the lowest in a Northeast database of 18 hospitals with like programs. So we already know that our complication rate is very low. And also how long the patients stay in the hospital. As we said earlier, they're staying about 2.5 days. So that's an indication of how we're mobilizing the team, the therapists, the nurses, the PAs, the surgeons team, that we're really mobilizing a group that knows what they do, they know it well, we're well preparing the patients so that everything goes off very smoothly. And when it's all done, we still follow up with the patients. And in fact, we're having, every year we invite the patients back for an annual reunion event. So we're inviting 300 patients next month to join us
Let me
for
ask you
a
sort of a
reunion.
detailed question, but one that as a patient sitting at home, or a potential patient, I'd wonder about. Can I get my knee replaced or my hip replaced? I go home in 2.5 days. I still need physical therapy. Do I get in a car and drive to get it? Do we send people into the home? How do they maintain the
That's a good
level of
question.
rehab that they need from being home, being home in location?
That's a good question. One thing that people don't think about is being home in and of itself is the best therapy that you can have. Just being at home and being in your own environment and doing the activities of daily living. But yes, a lot of patients do go home with a physical therapist who comes to work with them in their environment, on their own stairs, practicing on their own driveway, or getting in and out of their own car. And then eventually they will progress to outpatient therapy. But it's definitely a progression, and one that just goes very smoothly.
How if my bedroom is
level.
upstairs? Do we put the bed downstairs for when they first go home?
That is an option, and those are things that we talk about extensively in the pre-op class. So setting your environment up for success, setting your social network up for success. Stairs, strangely, actually don't end up being a big barrier for people to go home. A lot of people are worried about that.
Yeah, they're climbing stairs before they leave.
That's really impressive to know. What about, though, Mark, I'll ask you this. I'm sure you have patients who come in with a higher level of activity or expectation to get back to more than just climbing stairs to get upstairs to the bedroom. What about those that want to get back to skiing or other sports? How do you sort of set their expectations, and what's realistic, what's maybe not so realistic?
Well, I think the one thing we want to avoid for joint replacements long term is high impact activity. So as someone who's a chronic runner, that's the one thing I probably wouldn't let them go back to. I mean, your ability to run is there. I mean, if someone's chasing you, you can run. But that kind of high impact activity is probably not good for the joint long term. But everything below that is reasonable to do. Skiing, doubles tennis, hiking, biking, like Zumba, dance, all kinds of things. We've taken care of several professional dancers, dance teachers, and they've gotten back to it.
Has this evolved, or do you see that people can be much more active today than 10 years ago or 20 years ago after joint replacement?
For sure. I mean, part of it is what people bring to us. They're more active in general. And most people are doing more than maybe everybody in general did 10 years ago. But we're also more confident with our joint replacements. We're able to use bigger implants that have more range of motion. People are not worried about dislocation. We don't even use joint protection after surgery because our risks of dislocation have become so low, we don't have to worry about it. So it's a response to what people want, but also a response as technology gets better.
We have like 15 seconds left. Just, if somebody has heard this and is interested specifically in this program, do they call the hospital? Do they call you? How do they get involved?
They could call the hospital and ask for me, the coordinator of joint replacement program, or call
Coastal Orthopedics.
Coastal Orthopedics, okay. Because this really is a well-developed, successful program with
and there's
tremendous results.
Also websites on the Norwalk Hospital as well as Coastal Orthopedics, so you can look those up.
Great. Well, thank you both so much. We're going to keep you around for the answer to today's questions, but we're going to take a break now. When we come back, we'll have the answer for today's health question.
Right now, we're going to take a look at some of the future events that are sponsored by Western Connecticut Health Network. This week's health question is, what causes a meniscus tear? And fortunately, we have
perfect person, right?
experts here
Right.
who will tell us.
So I guess the first question is, what is a meniscus? And that's, people,
probably
right? So there's cartilage in the end of the bones, and that's akin to the ends of the chicken bone if you're having chicken. Those are the two smooth pieces that allow the joint to move. But the meniscus is an additional piece of cartilage that decreases the force across the joint. And so these C-shaped, semilunar, or meniscus-shaped cartilages are in there as a shock absorber and as a stability mechanism. We see them very, very often, but typically it's a very high forceful bend or twist, and that causes the way the knee rolls. It rolls back on the tibia, and that traps the meniscus. And so people who fall, it could be even as subtle as stepping off the curb awkwardly, but it's usually some sort of bending and twisting combination. And afterwards, maybe you don't swell or bruise, but you'll notice that your knee's a little sore, and afterwards, every time you get into those deep bending or twisting movements, you'll feel a sharp pain that's usually relieved when you start walking straight. So a meniscus tear doesn't hurt all the time. It hurts when you get out of the car, when you climb upstairs, when you turn. And so we call that mechanical symptoms. So the joint itself still works. It's just if you put it in a certain position, the meniscus
You
gets hurt.
just sew that up as a repair? Is that the
Well, if it's a very small one, a lot of times we just trim out that tear. But if it's a large one, we try to repair it. But not every part of the meniscus can heal.
So it's great that you've outlined very nicely for us what to look for. So getting out of the car, certain movements of the knee, sharp pain would be an indication to come see your friendly orthopedic surgeon.
And that's all we have time for.
That's all we got.
So, Vicki,
If you have a question that you would like to ask Eric and myself on Health Talk, please contact us at healthtalk@norwalkhealth.org.
Vicki and I want to thank our guests today, Dr. Mark Fletcher and Deborah Kinnett, for coming on our show and telling us about joint replacement. It actually made me feel a lot better.
My pleasure. Thank you.
We will see you all next week on Health Talk.